This topic is the cardiovascular system, and in this review we're going to talk about ischemic and valvular heart disease, heart failure, arrhythmias and devices including intra-aortic balloon pumps, pacemakers and AICDs, and pericardial disease. The risk factors for ischemic heart disease include the typical conventional risk factors such as age, family history, sex, and race, and then there are the modifiable ones: hyperlipidemia, hypertension, tobacco use, diabetes, metabolic syndrome, and a sedentary lifestyle. The Revised Cardiac Risk Index is an index determining the probability that the patient will have an adverse cardiac event after surgery. And it takes into account the surgery, and high-risk surgeries include intrathoracic, intraperitoneal, and suprainguinal vascular. The presence of ischemic heart disease, either as an MI, a positive stress test, chest pain, nitrate use, or Q-wave on the ECG, the presence of CHF, cerebrovascular disease, a creatinine of greater than 2, and insulin-dependent diabetes. There's 1 point for each risk factor, and the more risk factors, the higher the incidence of major adverse cardiac events, which are described as an MI, BFib, pulmonary edema, cardiac arrest, and heart block. The manifestations of ischemic heart disease include angina, dyspnea, myocardial infarction, heart failure, arrhythmias, and sudden death. To modify the risk, patients may be on beta blockers, and they're associated with the reduction of cardiac events, but the problem is that there's few data available to support pre-op beta blocker use to reduce the risk of surgical death. There's also an association between beta blockers and adverse outcomes, including an increased incidence of stroke and death in patients who are naive to beta blockers. The AHA recommends that beta blockers should be continued in patients on chronic beta blockers, and then the perioperative management of beta blockers should be dependent on clinical circumstance. It's reasonable to start preoperative beta blockers in patients with intermediate or high-risk ischemia on pre-op testing, or if the patients have greater than 3 risk factors on the RCRI. If there's a compelling long-term indication for beta blockers but no risk factors, perioperative beta blockers have an uncertain benefit. And if beta blockers are to be started, they should be started more than 1 day before surgery to assess safety and tolerability, optimally between 2 and 7 days before the procedure. Beta blockers started on the day of surgery are ineffective and may be harmful, especially in beta blocker naive patients. Statins are to be continued if started preoperatively. They're reasonable in patients undergoing vascular surgery, and they should be considered in patients with 1 risk factor undergoing high-risk surgery. Aspirin in elective non-cardiac surgery without stent should be continued if the risk of adverse cardiac events is greater than the risk of bleeding. Medical treatment of ischemic heart disease, statins to lower lipids, treating hypertension, MI prevention with aspirin and other antiplatelet agents, ACE inhibitors and beta blockers, and symptom relief with nitrates, ranolazine, beta blockers, and calcium channel blockers. Thoracic epidural analgesia has also been used to treat intractable ischemia. It produces a sympathectomy that blocks the cardioaccelerator fibers T1 through T4, reducing heart rate, preload, and afterload. It has no effect on coronary perfusion pressure, but increases the luminal diameter of coronary arteries. This improves regional and global ejection fraction. Another controversy is revascularization before surgery. A CABG is recommended before non-cardiac surgery if indicated by existing guidelines. A CABG to reduce perioperative risk is not recommended and is deemed harmful. With percutaneous coronary interventions, indications include left main disease and patients who are too high risk for CABG, unstable coronary artery disease requiring urgent or emergent revascularization, and if PCI is required before surgery, an angioplasty or bare metal stent should be inserted. So the timing of elective non-cardiac surgery after PCI. Class 1 indications are to wait 14 days after an angioplasty, 30 days after a bare metal stent and a year after a drug-eluting stent. A Class 2B indication is elective non-cardiac surgery after drug-eluting stent placement greater than 180 days if the risk of delay is greater than the risk of ischemia and stent thrombosis. These are the AHA guidelines for stents and anticoagulation. In a patient with a coronary stent, if the stent implantation was less than 4 to 6 weeks and it's elective surgery, you wait. If it's not elective surgery, you continue antiplatelet therapy unless the risk of bleeding is greater than the risk of stent thrombosis. If it's more than 4 to 6 weeks, if it's a drug-eluting stent, but less than 365 days, again, you wait if you can, and if you can't, you try to delay surgery until 180 days, and you continue the antiplatelet therapy unless the risk of the surgical procedure is more than the risk of thrombosis. If you have to stop the antiplatelet therapy, you stop the Plavix first and then restart it as soon as you can. For pre-op cardiac testing, you're looking at functional status. It's a predictor for perioperative and long-term cardiac events. If they're highly functional and asymptomatic, you proceed to surgery. If no stress test is available, you can measure functional capacity by METs. Excellent would be greater than 10, good would be 7 to 10, moderate would be 4 to 6, and poor would be less than 4. ECGs should be considered if the patient has coronary artery disease, arrhythmia, peripheral arterial disease, cerebrovascular disease, and structural heart disease, unless it's a low-risk surgery. A Class 2 indication, it can be considered in asymptomatic patients without known coronary artery disease, again, unless it's a low-risk surgery, and there's no benefit in doing an ECG in asymptomatic patients undergoing low-risk surgeries. The preoperative echo is reasonable if the patient has dyspnea of unknown origin, a history of heart failure with worsening dyspnea or a change in clinical status, or to reassess LV function. It's not recommended for routine pre-op testing, and a low ejection fraction, an ejection fraction less than 35%, is associated with increased heart failure and mortality. These are the 2014 ACC AHA guidelines. A patient scheduled for surgery with a history of coronary artery disease first is determined whether it's an emergency or not. If it's an emergency, they go right to the operating room. If they have ACS, you can evaluate and treat according to guidelines. If not, you estimate the risk of MACE, and then if it's low risk, you go to surgery. If it's elevated risk, you determine the functional capacity. If they have excellent functional capacity or moderate to good functional capacity, you can proceed to surgery. If they don't have good functional capacity, or unknown functional capacity, you can do testing, especially if it's going to affect your care. You do the testing and you either revascularize or you go to surgery. Cardiopulmonary stress testing is used for patients undergoing high-risk procedures, and a VO2 less than 10 milliliters per kilo per minute is associated with MACE. Pharmacologic stress testing is used in high-risk surgery in patients with poor functional capacity if it will change management. Stress tests are not useful for low-risk surgery, and perioperative coronary angiography is also not useful. The perioperative goals are to optimize myocardial oxygen supply and demand. Myocardial oxygen supply is dependent on the arterial oxygen content, which is the oxygen on hemoglobin calculated by 1.34 multiplied by the hemoglobin and the oxygen saturation, plus the oxygen in the plasma, which is calculated using the PaO2 times the solubility factor of oxygen in blood. It's also dependent on the cardiac output and the coronary blood flow, which is dependent on the coronary perfusion pressure, heart rate, vascular tone, and the presence of atherosclerotic plaques. Myocardial demand is dependent on the heart rate, contractility, wall stress, preload, and afterload. Perioperative ischemia can be precipitated by decreases in supply, such as anemia, hypoxia, and decreased coronary perfusion pressure, and increases in demand, tachycardia, hypertension, increased contractility, and increased wall tension, which can occur during LV fluid loading. Many episodes of perioperative ischemia are silent. Other causes of silent ischemia are diabetes and a previous MI. Postoperative ischemia presents usually on postoperative day 0 or 1. The majority are silent because of analgesic use. They're associated with increased heart rate, which is the major cause, contributing factors such as hypotension, hypertension, anemia, hypoxia, and hypercarbia. They present with ST depression and a small troponin leak. They're diagnosed through ECG. 90% of ischemia can be detected by leads 2 and V5. ST depression can be caused by endocardial ischemia, ST elevation by transmural ischemia or air. T-wave can be flipped or flattened, or the EKG can start looking more normal, which is called pseudonormalization. A PA catheter is the worst monitor for ischemia. You look at the morphology of the waveform and not the absolute pulmonary artery pressure. A V wave may be seen, but it's not specific. Echo is the most sensitive monitor for ischemia. It can also be used to monitor ventricular function, fluid status, valvular function, tamponade, unexplained hypotension, the presence of intracardiac air, either aortic atherosclerotic vascular disease, aneurysms, or dissections, a PE, especially in the ortho or liver transplant rooms, intracardiac shunts, and cardiac, aortic, and pulmonary trauma. Here is a diagram showing the coronary artery distributions of the 3 major coronary arteries, blue being the RCA, the green being the LAD distribution, and the pink being the circumflex. Here is an example of perioperative ischemia. On the left, there's a normal heart. On the right, the circumflex artery was clamped, showing lateral wall, regional wall motion abnormality. The treatment is to increase myocardial oxygen supply, which means increasing oxygen, red cells if anemic, and to maintain coronary perfusion pressure, which is defined as the difference between the aortic diastolic pressure and the LV EDP. Medical treatment, beta blockers, alpha-2 agonists, nitroglycerin, vasoconstrictors, and intra-aortic balloon pumps. Beta blockers inhibit sympathetic activity by blocking beta receptors. They decrease chronotropy and inotropy, they increase the duration of diastole, they have antiarrhythmic properties, and they're synergistic with nitroglycerin. They're used for sinus tachycardia, SVT, and aortic dissection, and contraindications include reactive airway disease, severe LV dysfunction, heart block, and diabetes. Alpha-2 agonists are used in patients intolerant to beta blockers. They attenuate hemodynamic instability, decrease central sympathetic and peripheral norepinephrine release. They dilate poststenotic coronary arteries. They provide anxiolysis, analgesia, and sedation. They reduce anesthetic requirements, and they decrease shivering. The disadvantage, there's a rebound effect when discontinued. They can also produce hypotension, bradycardia, and a dry mouth. Vasopressors are used to increase diastolic blood pressure, and they cause reflex bradycardia, and these include phenylephrine, norepinephrine, and vasopressin. Nitroglycerin, it acts through a mitochondrial aldehyde dehydrogenase, which forms nitric oxide, which activates the enzyme guanylyl cyclase to form cyclic GMP, which activates a protein kinase to cause calcium to go into the sarcoplasmic reticulum. It's more of a veno than an arterial dilator, and it's a coronary arterial dilator. It will decrease preload in heart size, increase coronary blood flow, especially to ischemic myocardium, and decrease both systemic and pulmonary vascular resistance. The disadvantages, it decreases blood pressure, there's reflex tachycardia, there's tolerance, there's rebound coronary vasospasm when discontinued, and it can produce methemoglobinemia. The intra-aortic balloon pump is used when patients fail to wean from cardiopulmonary bypass, when there's continuous ischemia, low ejection fraction, or high-grade coronary artery lesions. Contraindications include sepsis, aortic insufficiency, or severe peripheral vascular disease. It works by a balloon inflating during diastole to increase diastolic pressure, thereby improving coronary blood flow. During systole, balloon deflation reduces LV afterload and wall tension. The balloon pump needs to be synchronized either through the ECG, and it's usually the largest deflection or the QRS wave, or the arterial pressure waveform. The timing, the balloon has to be inflated at the start of diastole, and it's timed during the dicrotic notch. There are two types of perioperative MIs. The first type is due to plaque rupture or stent thrombosis, and it occurs earlier in the perioperative period. Type 2 is a myocardial oxygen supply-demand mismatch. It usually occurs later, either during emergence or into the postoperative period. Type 1, there's atherosclerotic plaque instability causing rupture and thrombosis. The plaque rupture then exposes lipids, leading to platelet aggregation. Then there's local thrombosis with a decrease in the lumen, causing ischemia and MI. And this is precipitated by increased stress. Perioperative risk factors for plaque instability include increased catecholamines and cortisol, increased shear stress due to pain, hypothermia, anemia, tachycardia, and hypertension. This will cause coronary vasoconstriction and plaque rupture. Surgery itself is a procoagulant state. There's increased levels of procoagulant factors such as fibrinogen and von Willebrand factor. There's reduced anticoagulant factors such as protein C and antithrombin 3, and increased platelet aggregation. This means that there can be thrombosis in patients in CAD with reduced coronary blood flow, but in the absence of plaque rupture. Type 2 is an oxygen supply-demand mismatch, usually seen with obstructive stable coronary lesions, and it manifests as ST depression and with prolonged episodes of ischemia. Triggers: tachycardia, hypertension, anemia, and hypoxia, or hypotension due to bleeding, hypovolemia, or vasodilation. The signs and symptoms of a perioperative MI are rare because only 14% have chest pain and only half have signs and symptoms prompting further study. The reasons are because these patients are receiving analgesics, or they're intubated and sedated, or the pain can be explained by other disease processes or surgery. Diagnosis is through ECG. At the STEMI, it'll be greater than 2 millimeter elevations of the ST segment in 2 continuous precordial leads in men and 1.5 millimeters in women, or greater than 1 millimeter elevation in 2 other leads, but they have to be contiguous. The initial Q or abnormal R develops over hours to days, or there could be a new onset left bundle branch block. With a non-STEMI, there are prolonged and repeated episodes of ST depression, and arrhythmias can be seen. Medical treatment includes beta blockers, alpha-2 agonists, nitrates, antihypertensive, phenylephrine if hypotensive, and a balloon pump. Systemic anticoagulation if not contraindicated, including aspirin, systemic heparinization, and thrombolytics, PCI, angioplasty, coronary atherectomy or stent, or CABG. With an off-pump CABG, the benefits of avoiding bypass: reduces systemic inflammation, bleeding because it requires a lower ACT, less renal dysfunction, AFib, or post-op intubation, and it has been shown to be better in high-risk patients. The disadvantage of off-pump CABGs is there's a question of the long-term patency of the grafts versus patients done on pump. The anesthetic considerations: there'll be hemodynamic instability during heart manipulation or ischemia during clamping of the coronary artery. It's difficult to diagnose the etiology of hypotension because the amplitude of the ECG is decreased and there's poor TEE imaging during manipulation of the heart. The hypotension is worst with the circumflex or the PDA. There'll be decreased regional wall motion due to compression or suction by the stabilization device. This decreases stroke volume, blood pressure, and coronary blood flow, and the treatment of this is fluid, Trendelenburg, vasopressors, and inotropic agents. This will increase CVP and RVEDP, and there'll also be distortion of the mitral and tricuspid valve, which exacerbates pre-existing regurgitation. Off-pump CABGs are converted to bypass if there's unresponsive refractory hypotension, malignant arrhythmias, severe new regional wall motion abnormalities, cardiovascular collapse, and is associated with higher morbidity and mortality. Risk factors for conversion include heart failure, a recent MI, a low EF, a redo, sternotomy, mitral regurg, or COPD. To perform bypass surgery or off-pump surgery, heparin is required. It enhances the activity of antithrombin 3. Antifibrinolytics are used on bypass. The two most common are aminocaproic acid and tranexamic acid, which bind to plasminogen and plasmin. And to reverse the heparin is protamine. It's a cation which binds to heparin and neutralizes it. The problem with protamine is that there are reactions. The first is hypotension. Due to histamine release, it's the most common reaction, and it can be treated with fluid and vasoconstrictors. Protamine can also induce elevated PA pressures due to complement-induced anaphylatoxins. This is treated with hyperventilation, pulmonary vasodilators, and systemic vasoconstrictors. Anaphylactic reactions are IgE-mediated. The treatment is supportive to stop the protamine, 100% oxygen fluids, bypass if you still have your cannulas in, the definitive antihistamines, epinephrine, corticosteroids, aminophylline, and bicarb. When placing a patient on cardiopulmonary bypass, there needs to be an arterial cannula either in the ascending aorta, the femoral, subclavian, or axillary arteries. The arterial cannula infuses blood into the body, and complications include kinking, dissection, and migration. The venous cannula can either be in the right atrial appendage, the bicaval, SVC, IVC, or femoral arteries. They collect blood from the heart, and a complication of the upper extremity cannulas can produce SVC syndrome. There's also antegrade cardioplegia to arrest the heart, which is inserted into the aorta. There's retrograde cardioplegia in the coronary sinus, and an LV vent to de-air the heart during open chamber procedures. This is a typical cardiopulmonary bypass circuit. The blood is drained from the right atrial appendage, goes into the venous reservoir, goes through pumps that oxygenate, add CO2, heat or cool, and then go back into the aorta. There are cardioplegia pumps, and there are pumps and monitors to look for oxygen saturation, venous saturation, and electrolytes. When weaning from bypass, hypotension is common. The differential diagnosis includes hypovolemia, and the treatment is fluid, contractility problems, which are treated with inotropes, balloon pumps, or ventricular assist devices. Decreases in SVR are treated with vasopressors, and problems with rhythm are treated with antiarrhythmics, cardioversion, defibrillation, or pacemakers. Aortic stenosis is either tricuspid, bicuspid, or unicuspid. In aortic stenosis, there's an increased gradient between the LV and the aorta. This increases wall stress, causing LV hypertrophy with decreased LV compliance. This eventually increases the left atrial and PA pressures, eventually causing LV dilation and systolic failure. On the left is a normal aortic valve. On the right is a valve with aortic stenosis. Notice the calcifications in the narrow opening. The anesthetic management is to keep everything normal. You want the preload normal to slightly increased due to decreased compliance. The afterload should be kept in the normal range to maintain coronary perfusion pressure, and the agent of choice is phenylephrine. The rhythm should be sinus to maintain cardiac output because these patients are dependent on their atrial contraction for filling. Atrial fibrillation can deteriorates to ventricular fibrillation. The rate should be normal, 60 to 70. If it's too fast, you decrease filling time. If it's too slow, you decrease cardiac output. Aortic regurgitation can be due to a bicuspid aortic valve, rheumatic heart disease, endocarditis, aortic dissection or trauma, or congenital. There's a decrease in forward flow from the LV into the aorta. This will cause systolic and diastolic fluid overload, causing an eccentric increase in LV thickness and size, causing LV dilation, and a compensatory decrease in SVR. Here is another aortic valve. If you look on the left, you see a normal valve with a normal Doppler. On the right, you see color flow in both systole and diastole, and this is a patient with severe aortic regurgitation. The anesthetic management is summarized in 3 words: full, fast, and forward. You want to keep them full because they have a lot of volume in their lower extremities. You want to decrease afterload to improve forward flow. You want to slightly increase heart rate to decrease diastolic time, and you want to maintain contractility. The etiology of mitral stenosis includes rheumatic heart disease and congenital abnormalities. There is left atrial fluid load with left atrial dilation, causing atrial arrhythmias and thrombi. This will get transmitted to the PA, causing increased PA pressures with pulmonary hypertension, ultimately leading to right ventricular hypertrophy, dilation, and failure. And since the LV doesn't see a lot of blood, it atrophies. On the left is a mid-esophageal 4-chamber view of a normal heart with the left atrium, mitral valve, left ventricle. On the right is a patient with mitral stenosis. Again, you see the left atrium, the left ventricle, but the mitral valve is thickened and restrictive. The anesthetic management includes maintaining preload. If it's decreased, you have a decrease in cardiac output. If it's increased, you have pulmonary edema. Maintain afterload to maintain coronary perfusion pressure. If possible, maintain sinus rhythm. These patients are usually in atrial fibrillation, but you want to decrease the heart rate to improve diastolic filling time. In mitral stenosis, you need to maintain the right and the left ventricular contractility and to decrease pulmonary vascular resistance to improve forward flow. The etiology of mitral regurgitation includes mitral valve prolapse, ischemic heart disease due to papillary muscle dysfunction, dilated mitral valve annulus due to cardiomyopathy, endocarditis, and rheumatic heart disease. There's increased left atrial volume and pressure, an increase in left atrial size causing atrial fibrillation, increased pulmonary artery pressures, LV dilation and hypertrophy to improve forward flow, increased LV volume and pressure, and an increased EF due to ejection into the left atrium and the aorta. On the left is a patient with a normal mitral valve. On the right, you can see the regurgitation in the left atrium. The anesthetic management is similar to that of aortic regurgitation. The preload should be increased unless the increased preload dilates the annulus. Both the systemic and pulmonary vascular resistance needs to be decreased to promote forward flow. The heart rate should be slightly increased to decrease systolic time. The contractility should be maintained. If the cause is ischemic MR, the goals are to avoid tachycardia and hypotension. Another type of disease that should be discussed here is hypertrophic obstructive cardiomyopathy. The etiology, there's abnormal myocytes causing hypertrophy. What happens in this disease is during systole, the hypertrophied septum and the anterior mitral valve leaflet cause left ventricular outflow tract obstruction. This obstruction is increased with tachycardia, increased contractility, decreased preload, and decreased afterload. and in diastole, there's impaired relaxation. If you look on the left, again, we have our normal four-chamber heart. On the right, you can see, this is a lung axis view, you can see the anterior mitral valve leaflet entering the LVOT. The anesthetic considerations: these patients should be kept full, the afterload should be kept high, and like aortic stenosis, phenylephrine is a drug of choice. The contractility should be decreased. The heart rate should be slow to decrease LVOT obstruction. These patients need to be in sinus rhythm, and they may require pacing. And inhalational use is a double-edged sword. It can depress myocardial function, which is beneficial, but can cause junctional rhythms, which is harmful. When do you prophylax patients for endocarditis? Only during high-risk cardiac conditions, such as prosthetic heart valves, a history of infectious endocarditis, a cardiac transplant with valvulopathy, and in those patients with congenital heart disease, either unrepaired, completely repaired for the first 6 months, or repaired with residual defects at or adjacent to the site of a prosthetic patch or a device. Heart failure. Heart failure occurs when the cardiac output cannot meet the metabolic demands of the body, or it requires increased filling pressures to meet this demand, resulting in end organ damage. It can be classified by the side of the heart affected, right or left, or the phase of the cardiac cycle, systolic or diastolic. Heart failure is classified using the New York Heart Association classification. 1, there's no limitation of physical activity. 2, there's slight limitation of physical activity where ordinary activity may cause fatigue, palpitations, and dyspnea. 3 is marked limitation of physical activity, so less than ordinary activity produces symptoms. And 4, symptoms of heart rate at rest. Systolic heart rate, the initiating event is increased wall stress. This can be due to myocyte injury, pressure, or volume overload. This causes pathologic LV remodeling, altering myocyte shape, arrangement, and filaments, ultimately leading to LV dilation, impaired contractility, and decreased cardiac output. Diastolic heart failure, also known as heart failure with preserved ejection fraction, you have an inability to relax and fill. The initiating events include alterations in collagen causing fibrosis, oxidative stress, decreasing nitric oxide and ATP, and alterations in calcium and sodium, which cause poor relaxation and arrhythmias. This results in a stiff ventricle with poor compliance, with a normal or near normal ejection fraction. On the left is a normal transgastric short axis view. In the middle is a patient with systolic heart failure, and on the right is a patient with diastolic heart failure. With heart failure, in order to try to restore cardiac output, there's activation of the neurohormonal systems. These will produce vasoconstriction and sodium and water retention. These include sympathetic activation, renin-angiotensin-aldosterone activation, causing ADH and vasopressin release. Then there's the release of natriuretic peptides, ANP and BNP. First it's adaptive, then maladaptive, eventually resulting in increases in SVR, inefficient cardiac energy expenditure, impaired contractility, and decreased tissue perfusion, and increased sodium and water retention due to causing pulmonary congestion and hyponatremia. The increase in catecholamines will produce direct myocyte toxicity, LV remodeling, downregulation of adrenergic receptors, changes in troponin, impaired calcium handling, and the facilitation of arrhythmias. The etiology of right ventricular failure includes pulmonary hypertension, cor pulmonale, due to morbid obesity or obstructive sleep apnea, left or right ventricular cardiomyopathy, RCA ischemia or infarction, tricuspid or pulmonic disease, left to right shunts, pulmonary embolism, and COPD. Perioperative causes of right ventricular failure include increased pulmonary pressures due to hypoxia, hypercarbia, and acidosis, pulmonary embolism due to thrombus, air, or fat, increased PEEP, decreasing venous return and cardiac output, volume overload, increasing RV-EDP and causing tricuspid regurg, and hypotension, decreasing RV coronary perfusion pressure and inducing ischemia. Symptoms: they're due to systemic venous congestion, hepatomegaly with anorexia, nausea, and pain, fatigue or dyspnea, and peripheral edema. Perioperative signs: hypotension, elevated CVP with low PA pressures, tachycardia, or new right bundle branch block or tricuspid regurgitation. Treatment includes inotropic agents such as catecholamines and milrinone, pulmonary vasodilators, such as the prostacyclins and nitric oxide, vasopressin, which increases right ventricular coronary perfusion pressure without increasing pulmonary artery pressures, oxygen, decreased PEEP, and red cells if anemic. The etiology of systolic heart failure includes coronary artery disease and hypertension, valvular disease, viral cardiomyopathies, hereditary or acquired cardiomyopathies, pregnancies, and toxins, such as alcohol, cocaine, and the chemotherapeutic agents. There are many causes of diastolic heart failure. The two biggest ones are coronary artery disease and hypertension, but as you can see, they're systemic causes, infiltrative causes like amyloidosis, myocardial causes, and pericardial causes. Heart failure presents as exertional dyspnea, orthopnea, PND, pulmonary edema, chest pain or palpitations, anorexia, fatigue, memory impairment and confusion, and cardiogenic shock. Heart failure is diagnosed using an ECG, echo, BNP, chest X-ray, cardiac MRI, cardiac catheterization, radionuclide multiple gate acquisition, and endomyocardial biopsy. The treatment is to treat the underlying cause: coronary artery disease, hypertension, valvular disease, or diabetes. Pharmacologic treatments include diuretics, beta blockers, ACE inhibitors, ARBs, aldosterone antagonists, nitrates, hydralazine, digoxin, and inotropic agents. Interventional treatments include PCI and stents, AICD, or pacemakers, or cardiac resynchronization therapy. Surgical, CABG, MVR, and LVAD, or cardiac transplantation. Precipitating factors for perioperative heart failure include acute on chronic heart failure, hypertension, tachyarrhythmias, anemia, hypercoagulability, excessive fluid administration, pain, surgical stress, and myocardial ischemia. It's diagnosed by signs of orthopnea, abdominal discomfort, and nausea and vomiting. Symptoms include tachycardia, hypotension, tissue hypoxia, hepatomegaly, oliguria, and a change in consciousness. Diagnosis: ECG, chest X-ray, BNP, and echo looking at right and left ventricular function, regional wall motion abnormalities, the etiology of the heart failure, and volume status. PA catheter can demonstrate a low cardiac index, a low mixed venous sat, and an elevated pulmonary capillary wedge pressure. The treatment of perioperative heart failure includes physiologic treatments such as optimizing oxygenation and ventilation and correcting acid-base abnormalities. Medical treatment includes beta blockers to control tachycardia, nitrates and antihypertensives to decrease SVR. Increased SVR can be treated with vasopressors, inotropic agents to increase cardiac output, and to produce a stable rhythm, antiarrhythmics. Interventional treatment, angioplasty, stents or balloon pumps, and surgicals, ventricular assist devices, and CABG. Arrhythmias are either due to changes in impulse formation or automaticity, or abnormal conduction or reentry. With automaticity, you have the abnormal generation of impulses, either from the SA node or ectopic foci, or abnormal atrial ventricular depolarization, either during the repolarization phase or the resting phase. Triggers: prolonged QT interval, low magnesium or potassium, increased sympathetic activity, and digoxin. atrial ventricular dilation, hypoxemia, or ion channel mutations causing or prolonged repolarization. With abnormal conduction or reentry, there's a pathologic circuit and the impulse travels around a functional or an anatomic loop. In Wolff, Parkinson, White, it's an anatomic loop, and with ischemia, it's a functional loop. It requires three factors: the presence of two conduction pathways, a unidirectional block in one of those pathways that prevents impulse progression but allows retrograde conduction, and reduced impulse velocity in the other pathway to allow time for the other pathway to depolarize. The treatment includes drugs that terminate reentry. They suppress the current responsible for phase 0, prolonging or blocking conduction in the reentrant circuit. And these are calcium channel blockers. They prolong the action potential and reentrant circuit refractory period, blocking impulse propagation. Risk factors include non-modifiable risk factors such as ischemic or dilated cardiomyopathy, autonomic nervous system changes to the conduction system, polymorphism of ion channels, and congenital prolonged QT syndrome. Modifiable risk factors include hypokalemia and magnesium. If it's low, it can cause torsade de pointes. If it's elevated, it can increase the QT interval, cause bradycardia, or first-degree AV block. Adenosine can be used to differentiate atrial from ventricular tachycardias. In reentry AFib or flutter, you have a transient response to adenosine. It does not terminate the arrhythmia. If it's reentrant arrhythmia in the AV node, it will terminate the arrhythmia. In ventricular tachycardia, it has no effect because the tachycardia is initiated distal to the AV node. So adenosine distinguishes a wide complex SVT from a VT because it will terminate the wide complex SVT. Ventricular arrhythmias can be named based on their QRS and based on their sustainability. Monomorphic ventricular arrhythmias have a constant QRS amplitude, and these are usually due to reentrant arrhythmias around the scar of an MI. With polymorphic ventricular tachycardia, the morphology of the QRS changes. It could be sustained or non-sustained, where sustained ventricular arrhythmia is 3 PVCs with a heart rate of greater than 100 beats per minute for less than 30 seconds. Non-sustained ventricular arrhythmias are usually benign unless there is a cardiomyopathy, and then they can convert to malignant arrhythmias. Another type of arrhythmia are those with prolonged QT intervals. A normal QT interval is up to 450 seconds. If it's prolonged, you can cause torsade. Drugs that delay repolarization cause torsades. They allow the formation of reentrant impulses. Risk factors include bradycardia, recent cardioversion of atrial fibrillation or heart failure, hypomagnesemia, hypokalemia, digoxin, any drug that prolongs the QT interval or polymorphic ion channels, and long QT syndrome. The treatment is to treat the underlying cause. Bradyarrhythmias can be treated with atropine, dopamine, epinephrine, or pacemakers. With tachyarrhythmias, SVTs are treated with adenosine, beta, or calcium channel blockers, VTs with amiodarone, cardioversion if unstable, and defibrillation with pulseless VTAC or VFib. With chronic arrhythmias, medical treatment includes slowing the rate with beta blockers or calcium channel blockers, anticoagulation, and amiodarone, or procedural, including cardioversion, ablation by interventional cardiologists, and the Mays procedure. There are many etiologies of perioperative arrhythmias, but the most important ones are hypoxia, hypercarbia, acidosis, and electrolyte imbalances, especially hypokalemia and hypomagnesemia. Pacemakers can be transesophageal, which are placed within 1.5 centimeters of the left atrium, transcutaneous, epicardial, and transvenous, which could be a lead, electrode, balloon, or PA catheter. They are inserted through the internal jugular vein into the right atrial or right ventricle and placement is confirmed using fluoroscopy or ECG. The nomenclature includes the first letter is the ventricle paced, which can be atrial, ventricular, both or none. 2 is the ventricle sensed. 3 is the response to the sensed event. It could inhibit, it could trigger, it could do either, or it could do nothing. 4 is a programmability or rate response. The programmability function, it could be multiple, single, communicating, or nothing. And the rate response is an on or off. And then the anti-tachycardia function, which is 5, you either have nothing, atrial, ventricular, or both. Common pacemaker modes include AAO, which is atrial pace, no sensing or inhibiting, usually seen in sick sinus syndrome with intact conduction and low heart rate. AAI, which is atrial pace and sense and inhibit, again in patients with sick sinus syndrome with intact conduction. VOO is ventricular pace, no sensing and inhibiting, third-degree heart block with AFib or only V wires placed by the surgeon. VVI, ventricular pace, sense, and inhibit, third-degree heart block with AFib. DOO, dual pace with no sensing or inhibition. This is usually an intraoperative mode in patients with third-degree heart block where the Bovie is going to be used. DVI, dual pace, ventricular sense and inhibit. These are patients with third-degree heart block with SVT. And DDD, which is one of the most common modes, dual pace, sense and inhibit, and these are used in patients with third-degree heart block. When assessing these patients preoperatively, cautery may interfere with the function. If they're dependent on their pacer, it should be changed to a fixed rate and interrogated after surgery. With preoperative AICDs, they should be turned off and defibrillator pads placed. The magnet is not recommended because it's unknown what the magnet is going to do. Bipolar should be used with the pad as far away from the device as possible, and it should be turned on after the case. The normal pericardium contains 20 to 25 milliliters of fluid. Pericarditis increases fluid accumulation. Pericarditis can be due to infectious agents such as viral, bacterial, TB, non-infectious processes due to trauma, malignancy, and MI, or autoimmune diseases such as rheumatoid arthritis, lupus, or rheumatic fever. Tamponade depends on the speed of the accumulation or the total volume of the pericardial fluid. What happens in tamponade? You have increased pericardial pressures, compressing the cardiac chambers, decreasing diastolic compliance and limiting filling. This eventually leads to hypotension with decreased coronary perfusion pressure and equalization of pressures, producing no flow and PEA. Tamponade presents with dyspnea, anorthopnea, tachycardia, peripheral vasoconstriction, pulsus paradoxus, which is defined as an inspiratory systolic pressure reduction of greater than 10, Beck's triad, which is a low blood pressure, high JVP, and muffled breath sounds. The ECG may demonstrate low voltage and electrical alterance, and the echo is used to determine effusion size and chamber collapse. Constrictive pericarditis can be due to infectious processes, pericarditis, cardiac surgery, mediastinal radiation, or idiopathic. It presents as tachycardia, fluid overload, fatigue, dyspnea on exertion, or Kussmaul sign, which is increased JVP with inspiration. There's little variation in volume with the respiratory cycle, so pulsus paradoxus is rare. There's impaired diastolic function, and filling depends on intra-abdominal pressure. There's a fixed systemic vascular resistance, and it's dependent on heart rate, and there's exaggerated ventricular dependence. To diagnose constrictive pericarditis, the ECG will show low voltage with upward sloping ST and T waves and AFib. The chest X-ray can demonstrate a ring of calcium around the heart. CT or cardiac MRI will demonstrate pericardial thickening and calcification, and an echo will determine the thickness of the pericardium and can look at the inspiratory posterior motion of the septum and diastole and a dilated IVC. This is an entity that can be diagnosed with a PA. In the PA tracing, there's a square root sign, which is a plateau following the Y descent, and the CBP will show an M configuration with plateau after Y descent. To differentiate constrictive pericarditis versus restrictive cardiomyopathy, you can look at the pathophys. With constrictive pericarditis, you have dissociation of the intrathoracic and intracardiac pressure and increased intraventricular dependence. And there are echo findings that are seen in restrictive cardiomyopathy, but not with constrictive pericarditis. LAE, left atrial enlargement, tricuspid regurg, mitral regurg, and LVH. And using the Doppler, the mitral valve E wave is normal in constrictive pericarditis, but decreased with restrictive cardiomyopathy. And the tissue Doppler E prime wave is greater than 8 centimeters per second in constrictive pericarditis because the heart itself is normal, but it's less than 8 in restrictive cardiomyopathy because it affects the myocardium. The anesthetic management, tamponade, can lead to cardiac arrest. So if the patient is an extremis, it should be local with sedation for a pericardial centesis before induction. The goals are in U1 invasive monitoring with large bore venous access to maintain preload, to maintain afterload, contractility, and heart rate, using ketamine, inotropes, and vasopressors, and to maintain spontaneous respiration because positive pressure ventilation can cause cardiac arrest. Inhalational induction with SIVO is possible. Thank you.